Buchanan from Italy. And this is, if she can find her way to the podium. This is past the first intelligence test, that's really good. So this is another case of acute myocardial infarction.
Hi there, my name is Louise Buchanan and I'm currently an interventional fellow at the San Raffaele Scientific Institute in Milan in Italy. I'm happy to be here today to present the case that I'm going to show you just now. Here are my conflicts of interest. So the patient I'm going to present this afternoon is a 78-year-old female patient, previously fit and well, with no significant past medical history other than that of hypertension, for which she was adequately treated on antihypertensive agents. She presented to the hospital with a 12-hour history of central chest discomfort, typically cardiac, some breathlessness, and then she developed some lightheadedness and felt quite dizzy on presentation. She was seen in the accident and emergency department, at which point she appeared to have quite cool peripheries. She was tachycardic with a heart rate of 110 beats per minute. Her blood pressure was low at 78 millimeters of mercury systolic, and despite high flow oxygen, she remained quite low oxygen saturations at 94%. Her ECG was performed immediately, which showed evidence of anterolateral ST elevation, as you can see there on the right, but there was evidence also of Q wave formation. She was seen there by the cardiology intern, who felt he heard a murmur, however did a transthoracic echocardiogram, which was reported as anterior hypokinesia but no other significant abnormality. So the decision was made, as she was having ongoing chest pain, that we should take this lady to the cath lab. Here was her diagnostic coronary angiogram, and as you can see there, her right coronary artery appears normal with no flow-limiting disease. And the angiogram of the left system shows a normal circumflex, with the most striking abnormality being the occlusion of the left anterior descending coronary artery, as you can see. At this point, she was becoming increasingly hypotensive, and as you can see there, her blood pressure was about 60 at this point. So an intra-aortic balloon pump was inserted immediately, and her hemodynamics improved with a systolic pressure of about 120 to 130. So it was decided to intervene on this lesion as an anterior infarct, low blood pressure, ongoing chest pain. A workhorse wire was taken to cross the lesion. This proved not quite so straightforward as it was thought, and an over-the-wire balloon was actually taken with the wire. And when the wire crossed the lesion, it was pre-dilated with a 2030 balloon at low pressure at only 8 atmospheres. Following pre-dilatation, there was still no flow. It was attempted to thrombus aspirate. Again, there was still no flow following this, and the operator at the time thought that something else was going on. It didn't all quite make sense. So a left ventriculogram was performed, and as you can see there with the pigtail catheter in the left ventricle, contrast is flowing from the left ventricle to the right ventricle and subsequently into the RVOT. So this was consistent with a significant ventricular septal defect, which on repeat echocardiography by the operator was demonstrated. So in summary, we have a 78-year-old female, previously well, recent anterior myocardial infarction with an occluded left anterior descending artery complicated by a post-infarct ventricular septal defect. Now in cardiogenic shock, although the blood pressure was maintained with the intra-aortic balloon pump. How would the experts treat?
Thank you very much. Come and take a seat. So Eric, could you come to the podium if you would, but I guess my first question is going to be to, I always have the first question to the cardiothoracic surgeon. So this is now post-infarct VSD, nice anterior infarct, patient unwell. Straight to theatre?
Well, I think this is the case where, yes, this is the time to break the glass, call in the cardiac surgeon, and I would say, balloon pump in, straight to theatre.
And being serious, and in your practice, that's what you would do?
That's what I would do, yes. Because I think, and this is a very typical case in the sense that it's usually, typically, it has to go with the disease. A lot of times the vessels are not really involved, so it's very key to function. Perhaps the presentation may be a little bit sooner rather than later, because normally it's a couple of days after the event. We don't really have the time So most of the time when we are called, it's really in the CCU and the registrar hears a new murmur 2-3 days later, and then we diagnose this. So given that you already have a diagnosis, and she's in cardiogenic shock, at this point I suppose she's still not intubated, so she's fairly stable. And so if you're not intubated on balloon pump, stable, there may be a case to say let's hold on, let's do some other investigations, let's do further risk stratification, but probably from my point of view, in a 78-year-old lady, more importantly, I need to talk to the family, and we need to go through the informed consent process and all those things, and then once all those things are sorted out, it's really surgery. I think the indication is very clear for this.
Okay, Eric, any thoughts?
Yeah. So this case represented another indication besides left main that you have to call the surgical colleagues urgently. So just to talk about the use of balloon pump in such a scenario of VSD during anterior line. So I had a check on the guidelines. Actually, it's a class 1 indication to putting in a balloon pump during such a case. And actually, just before the start of this angiogram, the blood pressure has already been seen to be lower than 100 millimeter per Hg. So perhaps even the intervention is, it's not wrong to put in the balloon pump even before the start of angioplasty. And then various benefits. More important.